All right, so patient-centered care, March 12th, cancer prevention in adolescents. How do we make a difference with Dr. Melissa Gilkey? Dr. Gilkey, welcome. We're really glad to have you here today.
Thanks so much for inviting me. I'm really pleased to be here.
Absolutely. So let's see what we can tell our audience about you. You're Melissa Gilkey, PhD. You're a seventh generation North Carolinian. Not everyone can say that. Uh, Her training at UNC has included a BA in English, an MPH in health behavior, and a postdoc in Lineberger's cancer control education program. And you completed your doctoral work at Johns Hopkins, but you don't think that should be held against you.
It was a
And we,
momentary lapse.
Okay. Okay. Well, we won't hold that against you. It teaches a graduate seminar in cancer prevention and control that was previously taught by her mentors, Michael O'Malley and Joanne Earp, who we miss dearly. Thank you for mentioning that as well. And prevention research has been published in journals such as Pediatrics and covered by media outlets, including the New York Times, NPR, and I had to stop in my tracks when I was going over this last one yesterday, The Onion. Tell us about that for a moment.
Yeah, the Onion covered one of my earliest studies, which was either a career highlight or low light. I choose to believe highlight, but just ripping on the idea that research is needed to convince people of the value of vaccines was the gist
Gotcha.
of their response.
Gotcha. Thank you for explaining that. And what else should we know about you from outside of your professional background here, a hobby or interest, something along those lines?
Yeah, well, as you'll see that my research portfolio has a strong focus on adolescent health. It's a research topic area that I've been passionate about for a long time. But I'll also share that I am the parent of two adolescents, an 11-year-old and a 14-year-old. So I'm not only reading about it and studying it, I'm really living it in real time.
Oh boy, and you're just getting into the thick of it. So good
That's
for
great.
you. Good for you. All right. Well, I mentioned poll everywhere. The first question, these are softballs. We hope adolescence is a great time for cancer prevention. True or false? While our audience is responding to that, I will flash up our disclosures. There, you've seen them. And then we'll take a look at the real-time responses to that question. We don't see numbers, we see percentages here. And looks, how are they doing? Well, I see 100% on the true.
Super. I knew we'd have a good call. We're off to a great start.
Good deal. Good deal. All right. Well, cancer prevention in adolescence, how do we make a difference? Dr. Gilkey, I'll turn it over to you.
Great, thank you. Well, I'll just say again how pleased I am to join the call today, and thank you for having me. As a social scientist, I always feel really lucky when I get the opportunity to speak with clinicians, nurses, and other people who actually deliver care. Typically, that's in the context of primary care, especially pediatrics. So it's really something special to be with an oncology-focused audience today. And I'm going to try wherever I can to connect my primary care perspective with the work that you all do. Before we get started, I'll note that I don't have any disclosures. And as you know, we're going to focus on cancer prevention today, and specifically on the communication side of things. And I always like to have a thesis for my talks, an argument that I'm trying to make, or something that I want to persuade you to at least consider, something that we might debate more actively in the Q&A. And my thesis for this presentation is the idea that we can prevent more cancer just by changing what we say. This is an idea I love, that in certain cases, we already have all the basic science, all of the technology, all of the know-how that we need to prevent cancer. We just have to communicate about it better. We just have to change what we say. Now, that may sound kind of unlikely, but in this presentation, we'll look at two examples of where communication can really make a big difference for cancer prevention: HPV vaccination and the prevention of early onset alcohol use. And so for each of these topics, I'm going to give you some background and share what research, including some research here at UNC, has to say about communication, about what we say. So starting with HPV vaccination. As you likely already know, HPV vaccination is part of the routine immunization schedule. And for most adolescents, CDC recommends that both males and females receive 2 doses by age 12. According to CDC, HPV vaccination can begin even earlier at age 9. And the American Academy of Pediatrics and the American Cancer Society actually recommend starting at age 9, just to give parents more opportunities to vaccinate. Adolescents who are not vaccinated on time can be vaccinated late on a catch-up schedule, but there's some downsides to that approach. So for example, kids who start HPV vaccination at age 15 or older need more doses of the vaccine, 3 instead of 2. And then as adolescents get older, their immune response is also less robust, which may translate into somewhat decreased effectiveness, while at the same time, their risk of HPV exposure goes up. So on-time HPV vaccination is important. And then, of course, childhood cancer survivors are a special case in that they typically need to wait until the end of active treatment to start HPV vaccination. And they most often receive 3 doses instead of 2. So the first part of my presentation will focus on the general population of adolescents. But if you'll bear with me, I'll bring that conversation back around to cancer survivors. So from my perspective, it's a really exciting time for HPV vaccine research because we're starting to see real-world effectiveness in terms of the vaccine's impact. The potential for vaccination to reduce the burden of HPV-related disease is really substantial. And to see that, I like the CDC infographic that summarizes the threat of HPV infection using an iceberg analogy. So the idea here is that when it comes to the burden of HPV disease, we've most often focused on that visible tip of the iceberg, or the 11,000 HPV-related cervical cancer cases that are diagnosed in the US each year. And cervical cancer definitely is important. Even with strong screening programs, it continues to kill about 4,000 women in the US each year, with a disproportionate burden on non-Hispanic, Black, Hispanic, and rural women. These are preventable cancers and deaths. But it's not just cervical cancer cases. So if we look underneath the tip of the iceberg, we can see that HPV infection is also associated with almost 200,000 cervical precancers. And then 5 other cancers, including about 14,000 oropharyngeal cancers. These cancers of the back of the throat are worth noting because they predominantly affect men, and they're becoming increasingly common. So oropharyngeal cancers now actually outnumber cervical cancers, and we don't have routine screening programs in place to detect them. So if we then zoom back out and consider the whole iceberg, we can see that HPV poses a big public health threat, including almost 36,000 cancers and 200,000 precancers each year. But the good news, of course, in all of this is HPV vaccination. So CDC estimates that widespread HPV vaccination at ages 11 to 12 could prevent over 90% of these cancers. And I hope you find these numbers compelling like I do, but I think what's even more compelling often is to hear about the experience of HPV cancer survivors and the clinicians and nurses who treat them. So I'd like to share this video clip from the National HPV Vaccination Roundtable. So I love that clip because I think the survivors in that video are so get just right to the heart of what's important here. And in particular, if you ever have a chance to hear Tamika Felder speak, I highly recommend it. She's just an amazing voice for cervical cancer survivorship. So with their encouragement in mind, I want to next take a look at how we're doing with HPV vaccination in the US. This graph is from the National Immunization Survey Teen, and it shows change in adolescent vaccination coverage over time. So here we're seeing the percentage of kids ages 13 to 17 who've been vaccinated over the years. And you can see HPV vaccination coverage in the bottom three lines. So that red line shows females who have had one or more doses. The green line shows the same for males. And that green-yellow line at the bottom shows the percentage of all adolescents, males and females combined, who are up to date on the series. So that's where we want kids to be. And in all three of the lines, you can see the slow but consistent progress over time with up-to-date coverage reaching 61% by 2023. That means that we're still a pretty long ways out from the Healthy People 2030 goal, which is actually 80%. And you'll also notice that HPV vaccination coverage is not nearly as high as coverage for two other vaccines that we give to adolescents, Tdap and meningococcal vaccines, shown in those top two lines. So it's not that we can't vaccinate adolescents. We do a really good job with other adolescent vaccines. It's that there's something different about HPV vaccination. So that's kind of the national picture, but you might wonder, how are we doing here in North Carolina? Well, let's start the quiz show portion of this presentation to find out with our first poll everywhere question. And that is, among US states, how does North Carolina rank in HPV vaccination coverage? Your options here are A, we're number one, we're the best. Of all the states, we're on top. B, we're number 2 to 10. We're leading the way. We're not the best, but we're in the top 10. C, we're number 11 to 30. We're kind of in the middle, but you know what? We're ahead of South Carolina. Or D, number 31 to 50. We'd rather not talk about it. So if you could please go to Poll Everywhere and weigh in on this question of how's North Carolina doing? Take just a few more seconds here. If you haven't entered your response yet, there's still time. Okay, this is super. So we're seeing some spread in the answers, with most people ending up with C. We're around number 11 to 30. We're in the middle of the pack, but we are ahead of South Carolina. And that is actually the correct answer. So North Carolina is currently 27th among states in HPV vaccination coverage, with 64% of adolescents being up to date by 2023. And again, we're using National Immunization Survey data here. And this is pretty typical for our state, where we tend to be in line or a little bit above the national average. And that may be that we have a lot of strengths in our state, amazing primary care providers, a really strong immunization branch at the State Department of Public Health, and also a good vaccine registry. And it's always nice when we can gloat about being better than our neighbors in South Carolina, where coverage is a bit lower at 61%. Of course, state rivalries aside, what I'm hoping this map really emphasizes that in both North Carolina and South Carolina, we have substantial room to improve. So check out some of those darker shaded states that are really leading the way and doing well, with the tippy top leader being Rhode Island, which has gotten their coverage to 84%. And so this should just kind of encourage us, excuse me, and give us a sense for what's possible as a goal to work towards. So let's continue our quiz show. Now that we've established that we have room to improve, I want to transition to thinking about how we improve. What's the way forward? What are the determinants of HPV vaccination? So sticking with Poll Everywhere to get us thinking about this topic, if you'll please weigh in on our second question. What's the strongest predictor of whether an adolescent will start the HPV vaccine series? Is it A, what parents believe about the vaccine? B, the child's race, ethnicity? C, the family's household income, or D, receiving a healthcare provider's recommendation to vaccinate? Which of these things do you think is most important? All right, we'll take a little more time here, so there's still time to respond if you haven't already. Okay, super. So it looks like our two primary answers are about half of people saying D, receiving a healthcare provider's recommendation, and the other about a third of the responses centering on parents' vaccination beliefs. The answer here is actually D, and this is surprising to a lot of people who assume that the main driver of HPV vaccination is parents' vaccination beliefs, their concerns, their questions about the vaccine. And parents' beliefs can be a barrier. One challenging aspect of HPV vaccine communication is that the reasons for HPV vaccine hesitancy among parents are diverse. The research has consistently found that reasons parents don't get the vaccine are that they aren't sure it's needed, it hasn't been recommended to them, they don't know enough about it, their child isn't sexually active, or they have some questions or concerns about safety or side effects. So there's not one single reason, but often there is an informational component to the concern that we can address. And what's more important is the role of healthcare providers' recommendation. So back to our theme about what we can say to promote cancer prevention. What healthcare providers say, as you would imagine, is especially important. So getting a recommendation is the strongest and most consistent predictor of starting the HPV vaccine series. If we think of recommendations as a kind of intervention, it's the most powerful one we have. We can look at this infographic. If we imagine 100 adolescents without an explicit recommendation, 47% of them will at some point start the HPV vaccine series. But with a recommendation, that percentage pops up to 75%. So recommendations are really that powerful. And the good news is that nationally, we're doing a lot better at delivering recommendations. Over 80% of parents of adolescents now report that they get a recommendation at some point, which is a lot better than it used to be back in the bad old days when fewer than half of parents got a recommendation. At the same time, there's more work to do because we want every parent to get a high quality recommendation for HPV vaccination. And we know that recommendation quality still varies. In particular, there's a need to improve recommendation timeliness so that kids get a recommendation at the first opportunity at age 9, and also urgency so that primary care teams make same-day vaccination available whenever they can. This is especially important for some of our high priority subgroups like childhood cancer survivors who are at higher risk of developing HPV cancers, have lower HPV vaccination rates, and less often get HPV vaccine recommendations. So what can we do to improve HPV vaccination? Well, one of the most effective strategies is to strengthen our communication so that the way we talk about HPV vaccination with parents really conveys our confidence and better meets their communication needs. So our team has developed a CME activity called announcement approach training that's designed to support primary care teams in using evidence-based communication strategies. The training consists of a 1-hour workshop in which a physician educator from our team meets with providers and nurses in their clinic. The training provides background on HPV vaccination, outlines effective communication strategies, and helps participants personalize and practice those strategies. So to give you a sense for the training's content, I want to share the 3 main steps that make up the announcement approach and that we summarize with this pathway infographic shown on the right. These steps have to do with using presumptive announcements, connecting with and counseling parents to address their main concern when questions arise, and trying again at a later visit if parents decline HPV vaccination. And we can look at each of these steps in more depth. So the first step is using a presumptive recommendation approach. So this involves recommending HPV vaccine in a way that expects a yes and makes routine vaccination the default choice. In this communication style, we try to normalize HPV vaccination by treating it just like all of the other vaccines in the routine schedule. To give a presumptive announcement, a provider can start by noting the child's age, emphasizing disease prevention by sharing that HPV vaccination prevents cancer, and offering the family the chance to start the HPV vaccine series that day. So, for example, a provider could say, Alex is now 9, so today he'll get a vaccine that prevents 6 HPV cancers. This is just one way to deliver a presumptive recommendation, and our training really encourages participants to adapt this approach to their own style so that it'll feel more natural and more comfortable to them. We have strong evidence that presumptive announcements like this one are effective. Our team, led by Noel Brewer in the Department of Health Behavior, conducted the first randomized controlled trial of this communication approach with 30 primary care clinics in North Carolina. In that trial, we randomized clinics to receive announcement approach training, a more open-ended communication style that we called conversation training, or no training in the control arm. We compared each intervention to the control in terms of change in HPV vaccine initiation or getting the first dose, and we found that announcement approach training outperformed the control condition by 5 percentage points in just 3 months. In contrast, conversation training did not have a statistically significant impact. As a result, announcement approach training is now recognized by the National Cancer Institute as an evidence-based intervention. I'll also note that since our study, several other randomized trials have replicated our finding that communication training, including the use of presumptive announcements, improves HPV vaccination. So again, we feel like this is an area where we have especially strong evidence. For many parents, a presumptive recommendation will provide all the information they'll need, and providers can move on with the visit. But other parents will have questions, and when they hesitate, our training teaches that it's important to slow down, connect with the parent, ask what their main concern is, and counsel them accordingly. This is step 2, and it's an important step because questions don't always mean that parents will refuse. They may just need more information. To help providers and nurses with these conversations, our workshop includes training on research-tested messages to address parents' questions and concerns. These are short messages that are designed to be easy to remember and that parents and providers have rated highly in our prior studies. In our training, we encourage participants to start with these brief messages and then elaborate on them as needed to more fully answer parents' questions and to kind of use their own counseling style. So here's a closer look at some of our messages. So for example, if a parent says their concern is that their child is too young for HPV vaccination, a provider can say, kids respond more strongly to HPV vaccine when they're younger. This may give better protection against some cancers. Another common concern is about why HPV vaccine isn't required for school entry in most states. For those parents, a provider can say, school requirements don't always keep up with the medical science. The HPV vaccine is an important vaccine that prevents 6 cancers. Other messages address topics like HPV vaccine safety and effectiveness. And some parents who receive additional information and support will be convinced to vaccinate. But we know that others will need more time. And so our last step, step 3, is that when parents decline HPV vaccination, providers should try recommending the vaccine again another day. So our prior studies find that declination is fairly common, but many parents, almost 70%, later get HPV vaccine or intend to do so. So for this reason, it's important that providers not get discouraged or give up, especially since HPV vaccine uptake is higher among adolescents whose providers have a follow-up conversation at a later visit. In our workshop, we encourage providers and nurses to set the stage for the next visit by letting the parent know that they'll have another opportunity for HPV vaccination and by making a note in the chart that the vaccine should be recommended again. Because again, our research really suggests that it's important to take the long view to vaccine decision-making. So that's a brief orientation to the key communication strategies taught in the announcement approach training, using presumptive announcements, connecting with and counseling parents to address their main concern, and trying again another day if parents decline. So to show you what that looks like in practice, I have a demonstration video to share. This one shows a pediatrician using the first two steps of the announcement approach, but who has pretty straightforward concern. And along the bottom of the screen, you can see the names of each step. Okay, again, that's a parent whose concern was pretty straightforward. Let's look at an interaction with a parent of an older child. And in this case, we'll see all three steps in the announcement approach because the parent has somewhat more serious reservations. And this scenario is also a little different in that the child needs multiple vaccines, not just HPV vaccines. So this also demonstrates a bundled approach to making that recommendation. Okay, so again, that's something of a tougher scenario, but hopefully it shows how by using a structured communication approach, providers can keep the conversation really positive and productive and kind of set the family up to revisit the decision at the next visit. So I already showed our research findings about the impact of the announcement approach training on HPV vaccination, but I'll also note some of our process findings that I think speak to the value and feasibility of communication training. First, providers and nurses like the training. They consistently rate it highly in terms of convenience and helpfulness. They also report that using the announcement approach is efficient and that it saves them time in clinical encounters with parents. In one of our studies, we surveyed participants before the training, asking them to estimate the amount of time they typically spent discussing HPV vaccination with parents. And then we followed up with them a month after the training to ask them the same question. We found that on average, the amount of time providers reported needing for HPV vaccination dropped by about 15%. So not only can communication training be good for HPV vaccination, it can also be good for the efficiency and flow of the clinical encounter. Finally, providers report that parents respond positively to the announcement approach. They like using it because it makes vaccine communication more organized and more comfortable sometimes by reducing conflict. Okay, so I want to switch gears a bit because I promised that we'd get back to the oncology context. We've been talking about communication in primary care because that's where I've spent most of my time as a researcher. But what does this mean for oncology providers and nurses? Well, over the last couple of years, I've had the really good fortune to work with two other researchers, Wendy Landier, who's at the University of Alabama, Birmingham, and James Klosky, who's at Emory, who are experts in pediatric cancer survivorship. And we worked together to develop an intervention that's adapted these best practices for vaccine communication in primary care and bring them to an oncology setting. We're currently evaluating that intervention to train oncologists to support HPV vaccination in survivorship clinics. As I mentioned, this is important because childhood cancer survivors are at higher risk of HPV cancers. And more specifically, that's 2 times higher risk for female survivors and 4 times higher for male survivors. In part for this reason, the Children's Oncology Group recommends HPV vaccination as part of long-term follow-up care. But even with these guidelines, research shows that survivors less often get a provider recommendation for HPV vaccination and are less likely to start the HPV vaccine series when we compare them to their peers in the general population. There are a number of reasons for this, including a lack of clarity about who owns HPV vaccine communication. Is it the oncologist or the primary care provider? As well as concerns among parents about whether HPV vaccination is safe and effective for survivors, along with an understandable desire to kind of minimize any further medical intervention that isn't totally needed since their kids have already been through so much. So this trial's ongoing. I don't have vaccination outcomes to share yet, unfortunately, but what we've found more anecdotally so far is that oncology providers can use many of the same communication strategies to recommend HPV vaccine that primary care providers do. So that means recommending HPV vaccination as the default choice, connecting with parents to really address their main questions and concerns, and following up with additional conversations if needed. Ideally, you can also offer HPV vaccination in your survivorship clinics, although that sometimes means expanding immunization services. So, for example, if you provide flu vaccinations, thinking about whether you could add HPV vaccination to the mix if it's not already. Finally, you have a role in supporting pediatricians and other primary care providers via referrals that can clarify what the vaccination schedule is for survivors. For example, that it typically involves 3 doses of HPV vaccine instead of 2. Not all primary care providers know this, so they could use your support in that way. I also want to share some of the survivor-specific messages that Drs. Landier and Klosky are testing to speak more directly to the questions and concerns that parents of childhood cancer survivors most often have. So, for example, when it comes to safety concerns, you can say, this vaccine has been studied specifically in cancer survivors and was found to be safe, just like HPV vaccination in the general population. For parents who are concerned about whether the HPV vaccine works for survivors, you could say something like, the HPV vaccine provides childhood cancer survivors with the same level of protection against HPV compared to kids who have never had cancer. Parents of survivors often also have questions about what's recommended in terms of timing or survivorship guidelines. So for these parents, you can say things like, now that your child has completed cancer treatment, it's the right time for him to get the HPV vaccine as part of recommended survivorship care. Or experts at the CDC agree that kids should get the HPV vaccine, and the HPV vaccination is recommended for childhood cancer survivors as part of the Children's Oncology Group survivorship guidelines. So these are meant to be really simple, straightforward messages that providers and nurses can just have top of mind and have ready to answer questions that may come up. With the upshot that HPV vaccination has been studied among cancer survivors and found to be safe and effective. So this is a little preview or sneak peek at this ongoing trial. We can look forward to seeing the effectiveness data in terms of vaccination outcomes, and hopefully also sharing our intervention materials more fully in the near future. So let's wrap up this section with one last poll everywhere. If you could please weigh in on this question: which of the following are evidence-based ways to improve uptake of HPV vaccine? A, introduce HPV vaccination with presumptive recommendations that expect a yes. B, use research-tested messages to address common concerns about HPV vaccination in a family-centered way. C, offer HPV vaccination at the next visit if parents initially decline the vaccine. Or D, all of the above. Give everybody a few minutes to chime in. Super. And of course, the answer here is D, all of the above. Well done. And thank you for participating in our quiz show portion again of this presentation. So that really completes our first kind of case study in HPV vaccination. And that's where I've spent most of my research career to date. But for this last part of the presentation, I want to look at an entirely different area of cancer prevention by sharing some research about the prevention of early alcohol use, which is a new research area for me. I think this line of work is exciting because we're hearing more and more about the link between alcohol and cancer, which has been understudied. But epidemiologists estimate that when we think about potentially modifiable risk factors, especially behaviors that lead to cancer, what can we actually change? Alcohol consumption is actually number 3 in that list in terms of importance. So only tobacco use and excess body weight are considered to be higher on the list. But if we want to prevent alcohol use, it turns out that it makes sense to go way back in time, actually, to adolescence, and in particular to focus on prevention of early onset alcohol use, which is defined in the research literature as any use before age 14. So we're likely all familiar or can bring to mind easily some of the social reasons that we might want to limit adolescents' alcohol use, but there are physiological reasons as well. And these include that alcohol seems to be uniquely harmful to children's developing brain and cognitive function, particularly in the context of heavy drinking. Alcohol can lead to problems in areas including brain development, learning and memory, attention, and impulsivity. As a general rule, these problems tend to get worse with younger age, so that they're more pronounced in younger adolescents versus older adolescents. Early onset of alcohol use is also problematic because it predicts future problematic use in later adolescence and adulthood, including alcohol use disorder. So there's this way that early use seems to set adolescents on a difficult pathway that can be hard to kind of get off of, and that has some real long-term consequences for them. When we think about preventing alcohol use in adolescence, we may think about the high school years, but the reality is that to stop early onset alcohol use, we actually need to start much earlier, ideally by 6th grade. And the reason for this is that when children enter middle school, they begin to be exposed to more opportunities to drink. And you can see that in this bar chart that shows the percentage of kids who have tried alcohol by grade. By the end of middle school, about a third of children report having had more than a few sips of alcohol, but that percentage is much lower, just 10% in 6th grade. So for this reason, we believe that 6th grade is really a key time for preventing early onset drinking. And that's much younger than often we are prone to thinking about. Another thing that's often surprising to people is that if we want to prevent alcohol initiation, we need to start in the home. Many of us, I think, imagine kids trying alcohol for the first time at a party with their peers when there aren't adults around. But a lot of early onset alcohol use actually begins in the home, and that alcohol is typically provided by parents. So why do parents do this? Well, there are a lot of reasons, including wanting to include kids in celebrations. But in the US, many of us also have the mistaken belief that it's beneficial for our kids to teach them how to drink in moderation at home. So for example, a 2012 study by UNC researchers found that a substantial minority of parents, 29%, believe that European families have less trouble with alcohol because they learn to drink at home at an early age. Unfortunately, it's actually the exact opposite of that's true. Many parents in Europe actually do allow their children to have alcohol, but more European teens abuse alcohol in comparison to the US. So it's actually more of a problem there. Similarly, around 40% of parents believe that if parents tell children they're not allowed to have alcohol, they'll only want it more. And this is similarly untrue. So longitudinal studies have found that giving kids even very small amounts of alcohol, what we call sips or tastes, increases rather than decreases alcohol-related problems. So it places adolescents at greater risk of binge drinking, and it makes them think more positively about alcohol use. It's also associated with faster adoption of heavy drinking. When parents give kids alcohol, it seems to backfire by actually making alcohol seem more attractive to kids because having sips makes them feel more grown up. Additionally, children receive a positive message from their parents about alcohol, and they learn that their parents don't mind them tasting alcohol. The thinking here is like, well, my parents wouldn't give it to me if there were anything harmful about it. And while some teens might drink a responsible amount when they're at home with their parents, a large body of research makes it clear that when parents aren't around, teens drink to get drunk. So it's not necessarily the case that what they do in the home will then carry over to other social settings. In behavioral research, we refer to this as alcohol socialization, or all the ways that we intentionally and unintentionally teach kids about how to use alcohol based on what we say and do. Think about all the times you may have heard somebody say, "Oh, it's been a long day, I need a drink." We often say this to be funny, but the implicit message is that we need alcohol to relax. Kids are also great observers and they learn from seeing us, right? Especially if they see adults who are drunk, including in person at family celebrations or even in the media. We can also unintentionally give kids opportunities to practice drinking. And this can happen, for example, when we serve them mocktails. It's meant to be fun, but it also is this opportunity to try on an essence of behavior. Alcohol use is so ingrained in our society that this process of socialization often happens without us even noticing. So in response, I have had the great luck to be included in an intervention study that has been led by a team of UNC researchers, including Nisha Gottfredson O'Shea, who is now at RTI, that is called Bypass. This is a text message-based intervention for parents. So we're switching here in terms of who the communicators are, from healthcare providers to parents. But it's designed to help parents talk to their kids about alcohol prevention by sharing key takeaways from alcohol prevention research, giving conversation starters and helping parents build their communication skills in prevention and in alcohol prevention, and also giving tips for limiting alcohol availability in the home and setting rules about alcohol use, because we know those rules really help kids by making it clear what the parent expects. And on the right, you can see a screenshot of one of the text message images that we send to parents who are participating in our intervention. So here, aim for lots of short conversations about alcohol is one of our tips. And you can hear a parent say to their child, "Since we're going to your grandparents' house tonight, let's talk about what we can say if someone offers you a sip of wine." So this sort of anticipatory guidance that parents can give to their kids. Our key messages for this intervention are that parents are the primary influence on children's drinking beliefs and behaviors, that prevention should start early, by 5th or 6th grade, and that the best policy for kids is no alcohol, not even sips or tastes. So on the right, here's another great screenshot from the intervention. What's your family rule about alcohol? We want you to be safe, and we care a lot about you. Our family rule is no sipping, no drinking, no exceptions. So again, this is another ongoing trial. Hopefully I might be able to come back in a later session to share some of the outcomes with you, although our preliminary data look really positive. But I think this is a really nice counterpoint to the HPV vaccine example of another really important opportunity, parent communication for cancer prevention. So I'm gonna sum up here. We'll wrap it up. But thinking back to my original thesis of the idea that we can prevent more cancer just by changing what we say, I hope that I have made inroads into convincing you that this is true. And just in terms of, some key takeaway messages, I want to emphasize that communication plays a really important role in cancer prevention for adolescents. Healthcare providers, including oncologists, are really trusted both by adolescents and their parents as prevention messages. So you all are important. And then finally, it's an exciting time to be in this area because research is really yielding evidence-based interventions that can help us improve our communication in areas like HPV vaccination and alcohol use prevention. So I'll end there, and I'm happy to take any questions. Thank you.
Dr. Gilkey, thank you so much. This is outstanding. I certainly learned a lot today. Let me go to our screen here and I'll look and see if we have any questions. And then I know I have a few. I'm just glancing at my phone because that's where I promote the questions onto the screen. All right. And the first one, with HPV vaccination education, do you feel, or is there evidence that shows that printed information on safety would be helpful to give hesitant parents in addition to verbal information?
So this is a great question. And of course, in primary care, Parents are typically getting some written information, the vaccine information
Yeah.
sheet, the VIS forms that are kind of CDC's technical than I would like rundown of what the vaccine is, what it's meant to protect against, and any safety or side effects issues that parents should know about. So they do get some information, but our intervention has actually made the conscious choice not to focus on written material through. And again, we're typically working in the primary care setting in a clinical context. And the reason for that is we think it's really important for parents to hear from their child's provider, right? Like that's and also nurses, right? Those are the people that they really trust and need to hear from. And our concern is that when you go the pamphlet route, sometimes that can take the place of that conversation, right? Like the focus really becomes on handing over this piece of paper that we know often goes in the recycling bin as soon as the parent is out the door, rather than really having that face-to-face encounter, which we believe is the thing that parents really want and need. So, I do think there's some opportunities there, but it's the interpersonal connection that's really important.
Gotcha. And let me extend that because I was thinking through this lecture, why I don't smoke personally. And I think of my fairly visceral response as a child to some of the things that I saw. The ad with the late actor Yul Brynner that was released after he had died of lung cancer, saying "Don't smoke, don't ever smoke." The things we saw in school of lungs of smokers and lungs of non-smokers, and then I think of our group is responsible for monitoring tumor boards, including the head and neck tumor boards, and I think of what our team hears and sees as cases are being presented of 50 to 70-year-olds who are now coming down with horrific head and neck cancers related to HPV. Are there ways in which conveying those sorts of things are effective, or just really again kind of adding on to in terms of the visual piece of that?
Yeah, so there's a really interesting literature in kind of the more communication campaign space, outside of the clinical counter that it suggests that there are strategies such as one that's called anticipated regret that can increase people's motivation and interest in vaccination. And there was a series of ads that Merck actually ran that tried to use this strategy, in which they asked parents to cast their mind forward to think about how would it feel if later your child got an HPV related cancer and you hadn't gotten them vaccinated. And they were controversial, right? Like they really kind of pushed the envelope in that for critics, it seemed like there was some guilt tripping involved, but those sort of strategies in which you bring to mind the future, which especially when you're the parent of a 9 or 10-year-old feels so far off, but help them really try on the consequences of a vaccine decision that are believed to help. Again, our team has always chosen to focus on the clinical context because it's more proximal to the actual decision and getting the vaccine. And so, can those kind of environmental messages be important? Absolutely. But it's when you're sitting in the office with the decision in front of you, with the potential of getting the vaccine in that moment, that are really powerful and important. So again, back to this message of providers and nurses they are really the key to getting our HPV vaccination rates up.
That makes a lot of sense, and very appreciative for the research that you do. One last question, and then we'll go ahead and start wrapping up. How do anti-vax parents defined as no preventative childhood vaccines react to HPV as cancer preventative rather than infectious disease preventative?
Well, I don't know of a study that has focused specifically on parents who completely decline vaccination, in part because it's important to keep in mind, despite what we hear in the media, there are so few of them. Vaccination is one of the strongest kind of social norms we have, right? Like well over 90% of parents get at least some vaccines for their kids. And can you think of any other topic that our country believes about that uniformly, right? It is a really strong social norm.
Yeah.
That said, parents do sometimes have concerns, especially about specific vaccines, including HPV vaccination. And we really believe that the key there is for providers and nurses to have the most positive conversation that they can have. And then if the parent declines, that's their right to do. But to, again, bring up the vaccine decision again at a later time, because a lot of parents just need more time, right? And so it is this more longitudinal process. And so even for parents who seem really dead set, like keeping that door open.
That is great to know. Well, let's go ahead. I want to share just your references, and of course, those are on the slides and will be in the recording and handouts. We want to say thank you. We want to say thank you to the state legislature for the University Cancer Research Fund that funds pretty much everything our group does. We want to thank the UNC Lineberger Comprehensive Cancer Center. We want to thank our team, Venny Obore, John Powell, Oliver Marth, Andrew Dodgson, Patrick Muscarella, and Barbara Walsh for all that they do. We want to thank Don Poe for Back Roads, the music at the beginning.